I have two talks back to back. So in the first one, we're going to kind of talk about second line treatments. And the reason we focus on this is I think for a long time we've had what we consider to be a first line therapy with ruxolitinib that really is, when you look across the board at even with the kind of emergence of other JAK inhibitors that have been approved, really ruxolitinib makes up the mainstay of frontline treatment for most patients with myelofibrosis. And so this talk is mainly geared towards myelofibrosis. I'll make some comments towards PV and ET, but when you think about the development of drugs and therapeutic agents in the setting of myeloproliferative neoplasms, everything typically starts with myelofibrosis, and then it trickles down to PV and ET. And so this still is going to be relevant for those diseases as well. So we'll start with this, and then in the next talk, I'll talk a little bit more about symptoms and how we kind of view those and how our existing therapies and emerging therapies address symptoms. Because I don't think that that's a small thing to focus on, because right now, as Dr. Rampal had mentioned, our goal in treatment of these diseases is really to have people live longer and live better. Unfortunately, we don't really have enough therapies right now that we know of that truly modify the underlying disease. So we do think we can make people live longer, but really the focus, 95% of what we do, is making people live better. And so symptoms is really what the main focus is on this. So let's start with talking about second-line treatments. And so why do we change treatment, or why do we move on from whatever we start with? And I think in the setting of myelofibrosis, we have a few different ways to understand why people switch from one treatment to another. And so if we look at the COMFORT trials, so the COMFORT trials are the trials that actually got ruxolitinib approved for myelofibrosis. COMFORT 1 was done predominantly in the US and randomized patients to either be on ruxolitinib versus a placebo. COMFORT 2 was randomized to be on ruxolitinib versus best available therapy. But in the long-term follow-up of these studies, they talk about what happened to patients at the end. And so why they came off treatment and what were the reasons for that. And so when you look at these, you can see that everyone discontinued the trial, right? So they had to come off the trial. Some went to just being on commercial therapy. Others passed away. Others had went to other sort of treatments. But here what you see is about 13.5% of patients came off of ruxolitinib due to some sort of adverse event, right? Some sort of side effect. 14%, about the same amount, came off for some sort of disease progression. And then treatment was ongoing. We say in 0, but this is just because it's the end of the study, right? So no one kept on the study treatment. But really, other reasons for coming off treatment would be kind of just deciding they want to come off. So they said like withdrawn consent or noncompliance, and then there's this other caveat, which is around 15%, which isn't that well defined. But really, when you talk about coming off treatment, for reasons other than passing away or unknown, it's either due to a side effect or it's because the disease progresses, right? So that's the main thing there. When you look at COMFORT 2, you see something quite similar, which is you see disease progression in around 20% of patients, adverse events in around 24%. So about equal again. The emergence of a side effect that causes people to come off treatment, or the disease is changing over time. But these are clinical trial scenarios, right? So they're not necessarily reflective of the real world. And so when you look at real world data, we have two different data sets here. So the top right one is our data set where we looked at patients that had come off of ruxolitinib. And what we found is the reasons for discontinuation really came down to low blood counts or cytopenias. This isn't something you'd see necessarily on clinical trials because those patients were actually pushed through a lot of those blood counts, and so that wasn't a main reason to come off. You saw non-hematologic adverse events, so some other side effect not related, only in about 6 patients of these, so much less likely to come off for a non-hematologic adverse event. And disease progression in only 7 patients. So again, in the real world, most patients are coming off due to side effects, predominantly low blood counts. And this was reflected also in an Italian data set as far as the reasons why patients came off, which is about a quarter of patients coming off for lack of response, some coming off for loss of response, but really 27% coming off for Rux-related adverse events and another 9%. So now close to 35-40% that are coming off due to adverse events, predominantly those that are related to Rux, which we presume are cytopenias, as those are the most common side effects. So this is why people move on from one treatment to another. Minor aspect is disease progression, but mostly due to side effects, predominantly cytopenias. And why do we care about this? Well, people have looked at how people do with myelofibrosis after they come off treatment, and inherently we don't have other great options for patients, right? Ruxolitinib was the only approved agent for a very long time until recently, and these data sets don't take into account what we've come up with recently or what's been recently approved. But this is from an Italian data set as well that said that after first-line treatment, outcomes are not that good. So we need better options. We also looked at this in our data set that said, okay, well, outcomes can be good if you go to transplant after ruxolitinib. So those patients actually did quite well, but that's only really relevant for a very small minority of patients who are able to undergo transplant for various reasons. We did show that if you receive some sort of therapy, salvage therapy we called it, because we didn't really have anything approved in the second line, you actually did better than if you got no therapy at all. So we know that there's value in a second line treatment, that patients can tolerate a second line treatment. We just need to come up with them. We're trying to now get a better sense of identifying patients that are going to come off therapy who aren't going to do as well, so we can identify patients who maybe we can come up with better strategies earlier. And so this is something that was recently developed called the RR6 model. And essentially this looked at patients that were on ruxolitinib to try to predict try to identify factors that would mean that they're not going to do as well long term. And what they found is patients that don't do as well long-term when they're on ruxolitinib are those that can't tolerate a high dose. So those higher doses tend to cause more low blood counts. Those that are needing a bunch of blood transfusions, and those that don't have a good spleen response. And so if that's the case, then this is an opportunity for us to identify patients earlier on who could benefit from an alternative therapy or a clinical trial or a different therapy, and therefore we could potentially improve outcomes in the second line setting. So currently, this is how we approach treatment from a second line setting. So we look, depending on why you're going to go onto a second line therapy, we said the main reasons for that are the disease progresses, or we deal with adverse events. All right, so in patients that have truly progressive disease, you can have that in one of two ways with myelofibrosis, technically speaking. Right, you can have the disease start to turn into something that looks like acute leukemia, or you can have progression of MPN symptoms or a big spleen. Those are kind of the two ways the disease can technically progress. In the setting of accelerated phase or blast phase disease, this is when it looks like the disease is turning into acute leukemia. This is certainly a rare occurrence when it happens, but it can happen in myelofibrosis patients. Probably around 5 to 10% of patients can progress to this over the course of 10 years. For this, we're using either something called HMAs or hypomethylating agents. These are infusions such as decitabine, Dacogen, or Vidasa, azacitidine. And this is what we give to a lot of patients that have acute leukemia or that have myelodysplastic syndrome. And then we give that with ruxolitinib or Jakafi in patients that are suffering from big spleens as well, because we still need to treat that underlying disease. So the goal there is to treat the underlying myelofibrosis as well as this kind of new acute leukemia that's evolving. Some patients, we can give them intensive chemotherapy. We tend to avoid this as much as possible, mainly because our patients who develop acute leukemia are very different than standard acute leukemia patients. These are patients that have had a disease for a long period of time. Their bone marrow is more damaged, more fibrotic, and so when we give them intensive chemotherapy, the recovery from that process is very challenging. So we tend to avoid that if possible. I will say, and the recent data that's been presented with hypomethylating agents tends to suggest that those patients have better outcomes than if you use intensive chemotherapy. On the other hand, you have patients where their myeloproliferative disease progresses in terms of their spleen getting larger or their symptoms getting worse. And in that, we have two additional JAK inhibitors that have been approved. Fedratinib, or Inrebic, was approved in August of 2019 and has data both in the frontline setting, that's very similar to what we see with ruxolitinib, but also in the second line setting where patients are able to have improvement in their symptoms and spleen even if they've previously received ruxolitinib. And then we have pacritinib, which was just approved on an accelerated basis at the end of February this year, which is technically approved for patients that have severely low platelets, less than 50,000, which is certainly important since I mentioned that one of the main reasons people have to come off of Jakafi is due to low blood counts. And so this is not necessarily a small population of patients that could benefit from pacritinib. Within NCCN guidelines, pacritinib can also be used as a second-line agent regardless of platelet count. As we know that in different studies it's shown to be effective, really agnostic to platelet count, but it's particularly safe in patients that have low platelets where we don't have other great options. Okay, so what happens if we come off due to adverse events? Well, it depends on what the adverse event is, right? So you have low blood counts, which we said was a main reason that people come off of Jakafi. In those settings, we can use pacritinib, right? We said that's safer for patients that have low blood counts. Doesn't tend to cause them to worsen as much. We have things like danazol. This is an androgen derivative. Danazol is able to improve blood counts in some patients, somewhere between maybe 20 to 40% of patients can improve their anemia. Also improves platelet counts if that's an issue that's being dealt with. Doesn't do much for the spleen, as far as we know, but it can help with these lower blood counts. Lenalidomide or thalidomide. So I learned about thalidomide from memorizing that Billy Joel song. We didn't start the fire, so there's this part, children of thalidomide. So I told you I was going to sing. There we go. Yeah. So I didn't know what that was, and I was a kid, and so I looked it up and then saw the pictures of all the birth defects, but it turns out that I was going to use that in practice. And so we do use it. It can help with anemia and actually can help with platelets. We just have to counsel patients very strictly on, not getting pregnant or having children. This always leads to a fun conversation in clinic with your 80, 85-year-old patient, and you're like, all right, so are you having sex with anyone who's of childbearing age? And he's like, oh, I wish. And you're like, God. Same joke every single time. This is always fun when we did this at the VA. It's just classic jokes every single time. So, but we still do use these agents. They can be helpful. We published a retrospective study a few years ago that says the clinical benefit, if you pick the right patients, is probably around 30 to 40% as far as improving anemia, reducing the need for transfusions. They obviously have side effects that can be quite challenging. We'd love to have better agents, but there's still a place for these for some patients. And then you have adverse events which are non-hematologic, in which case you have to figure out, okay, well, if we're coming off ruxolitinib for a variety of reasons, I think the side effects we think about long-term with ruxolitinib is reactivation of shingles, non-melanoma skin cancers, weight gain in some patients, and we really don't know the risk of those with these other JAK inhibitors, fedratinib and pacritinib, but presumably we may be able to switch patients to a different JAK inhibitor where those same side effects don't happen. And I mentioned here at the top that we should always be considering an allogeneic hematopoietic stem cell transplant, or what used to be called a bone marrow transplant, for appropriate patients. Whether first line, second line, whatever, if a patient is eligible for this and the disease is risky enough, this is something that patients should have the chance to meet with a transplanter to talk about that option, as this does remain the only curative option we have. So this is just showing some data, right? So I'll tell you that these graphs, we show these types of graphs a lot. So I think I start to forget that people might not know what they mean, but essentially each of these bars is a patient. If the bar goes down under that x-axis, if the bar goes down, that means either the symptoms or the spleen is getting better. So that's the degree of improvement if the bar goes down. Now, if the bar goes up, that means the spleen or the symptoms are getting worse. The nice thing, we call this a waterfall plot, and the nice thing about this is when you look at these populations, you can see most of those bars are going down. That means most people are improving. And so this is looking at fedratinib in the second line setting. So this is a study called the Jakarta-2 study that looked at patients who had previously been on Jakafi, but then had to come off for some reason, and then were put on fedratinib to see if they could get a better response. And so this is looking at it in a variety. I won't go into why they looked at it so many different ways, but actually I will. I was going to say I'm not going to go into it, and then I was going to go into it, so I am going to go into it. So when they did the study years before, the question was, was it up to snuff of what we consider to be an appropriate way to look at this when we were reevaluating whether fedratinib should get approved? And so they said, actually, I don't know if you defined ruxolitinib intolerance or resistance as well as we would like to have done that. So you need to go back in and apply these more stringent criteria to do that. So they did. They went back and said, okay, well, we re-looked at it now using the stringent criteria. Here's what the responses are. They look quite the same. So you can see in the intention to treat population on the left, the left two graphs are looking at the spleen volume. You can see that in most patients that spleen volume is improving. There's the bar that goes across. There's this 35% reduction, which we consider to be a true spleen response. That's somewhat arbitrary, but you can see across the board their spleen size is improving. If you look on the right, that's symptom scores. So people's symptoms in general are improving over time. So we do know fedratinib has a role in the second line setting in the correct patients. What we were also concerned about is what about in patients that have moderately low platelets, right? That we said a lot of patients are coming off of ruxolitinib or Jakafi because their platelets are too low. And so Jakarta 2, the study, did enroll patients that had platelet counts that were between 50 and 100, which is this kind of like borderline group of folks where we don't have great options for them. If they are on Jakafi, they're on lower doses of Jakafi, which tend not to be as effective. If they're on fedratinib, then they can actually be dosed at the full dose level, at least initially. And what they showed here is in this kind of lower platelet group, actually the responses in terms of the spleen volume response and the symptom responses were comparable to what we saw in patients that had higher platelets. So this can also be an option for folks with kind of borderline low platelets. Pacritinib, as I mentioned, is really approved now for patients with very low platelets, but has shown benefit in other groups of patients as well. And so this was the PERSIST-2 study, and this enrolled patients with platelets less than 100,000, and they got randomized to 2 different doses of pacritinib, which I'm only showing one because we don't recommend the 400 milligrams once a day. So they're randomized to either 200 milligrams twice a day or best available therapy, much of which was ruxolitinib. But again, ruxolitinib at a low dose because the platelets were less than 100,000. And what we can see here is, again, these waterfall plots. On the left, you have pacritinib. On the right, you have this best available therapy. And those orange bars that are mixed in there are the patients that were on ruxolitinib. And so you can see on the pacritinib side, most everyone is improving their spleen size. Most everyone is improving their symptoms. On the right side, which is the best available therapy, more of a mixed bag. All right, so in this patient population, it seems that pacritinib is able to probably do it a little bit better than we saw with best available therapy. When they looked back kind of retrospectively and said, let's compare pacritinib versus ruxolitinib in kind of a post hoc analysis in patients that have low platelets. And so they looked at really these efficacy endpoints in terms of spleen volume response, symptom response, but also this thing called the PGIC, which is the Patient Global Impression of Change. Do I feel better? Do I not feel better? All right, so the very kind of patient-reported outcome. And what we see is in low platelet counts, when you look at truly pacritinib versus ruxolitinib, the spleen volume responses are better, which is not unexpected because, again, these patients, if they're on ruxolitinib, are going to be on lower doses, and the dose matters in terms of getting the spleen to shrink down. Pacritinib, they're fully dosed. Symptom response also appears somewhat better, although this isn't technically statistically significant because the p-value here is only 0.11. It has to be less than 0.05 for us to think that there's a huge difference, but it looks better, right? The bar's higher. And then the patient global impression of change, it seemed like those patients on pacritinib did feel like they were doing better than the patients that were on ruxolitinib. And when you look at the more details of this patient global impression of change with this bar graph on the right, those colors are kind of separated into those in red means that they feel minimally worse. This kind of whitish gray area is those that felt no change. Light blue is minimally improved. Darker blue is much improved, and this kind of black or navy blue is very much improved. So you can see the patients on the left on the pacritinib tend to feel a little bit better overall than the patients on the right. And honestly, these kind of patient-reported outcomes are extremely important because, again, we're talking about our goal is improving symptoms. So if a patient feels like they're doing better, that's a win for us. Obviously, we want the disease to go away, but we haven't been able to necessarily get those treatments to show that they can do that yet. So we definitely want people to feel better, and who better to tell us if they're feeling better than the patient themselves. Momelotinib, this is an emerging agent, hoping that we can get this drug to be approved sometime in June of next year. This has gone through a lot of development, so we know a lot about it. Had multiple phase 3 studies, the Simplify 1, Simplify 2, and then recently there was this Momentum study that was done where patients who are anemic, had big spleens, anemic, big spleens, and symptoms, and had previously been on Jakafi, were then randomized to either go on momelotinib or danazol. As I mentioned, danazol is an active agent for anemia, but we don't think it does a ton for spleen or symptoms, other than maybe symptoms related to anemia, where it could do something. And then the main thing we looked at is symptom score, or symptom response rate at week 24 after 6 months. And you can see on the left, there's those folks on momelotinib. Most of those patients' symptoms are improving. On the right, you have danazol. Again, more of a mixed bag. The reason why you see way more patients on the left than the right is this was a 2-to-1 randomization, so 2 people went on momelotinib for every 1 person that went on danazol. Look at spleen response rate. Again, we don't think danazol does a ton for spleen, so I'm kind of intrigued by these 5 patients or so that had spleen responses on danazol. That's awesome. Congrats, guys. But on the left, you can see that generally momelotinib shows the ability to improve spleen size or reduce spleen size in these patients. When you look at the rate of transfusion independence and hemoglobin over time, this is where momelotinib kind of sets itself apart from some of the other agents we've had, is that we tend to think that Rux and fedratinib make anemia worse, at least in the short term, right? So Rux has been associated with kind of a 1.5 to 2 gram decrease in hemoglobin within the first 3 to 4 months, and then it kind of recovers by 6 months, but it incompletely recovers, never gets back up to where the baseline was. Fedratinib, we also know anemia is a big part of the side effects associated with that. So the problem is anemia is quite common in patients that have myelofibrosis, and so it's hard to give someone a treatment that makes one aspect of their disease worse, but other aspects better, and it's kind of an awkward trade-off for some folks. So momelotinib also inhibits a protein or a gene called ACVR1, which is involved in anemia, and seems to be something that's relevant and may actually allow momelotinib to help with that. So this is something that was shown in these earlier clinical trials and something we really wanted to focus on, because this is one of the key factors that would set it apart from other JAK inhibitors. And when you look at this graph on the left, at the baseline, you can see that 13% and 15% of patients treated with momelotinib and danazol were what we call transfusion independent, not requiring transfusions at all. Okay, no transfusions whatsoever. At the end of the study, 24 weeks, 31% of the patients treated with momelotinib did not require any transfusions, compared to 20% of those on danazol that did not require any transfusions. So an improvement in this transfusion independence rate, compared to an agent that we know helps with anemia. So that's nice. When you look on the right, you can just see the average hemoglobin over time on the study. The blue bar is those patients that were on momelotinib, so you can see an initial improvement in that hemoglobin level, and then that stays stable out to 24 weeks. Danazol does improve hemoglobin as well, but just not to the same degree. After 24 weeks, patients on danazol could switch over to momelotinib, and all did, and that's why you see that graph start to reach the same level as the momelotinib graph, because those patients are switching over onto momelotinib. Talk about a few other emerging agents that are being looked at in the second line. Navitoclax has been something that is quite interesting. Its cousin, venetoclax, has kind of transformed the field of acute myeloid leukemia. Unfortunately, venetoclax for myeloproliferative neoplasm patients is not as effective, even in the accelerated or blast phase setting, unfortunately, but that's probably because the biology is a bit different in myeloproliferative neoplasms than true AMLs, and so navitoclax works a little bit differently and may be more relevant. So this is being looked at in the second line setting, as well as the frontline setting, but this was recently published in patients that were on ruxolitinib but still had some degree of an enlarged spleen. We call this kind of a suboptimal response. Navitoclax was added on and was able to achieve a true spleen response, so 35% further reduction in the spleen size, and around 28 to 30% of patients, which is quite encouraging, because these are already patients that have kind of deemed themselves challenging, or their disease is challenging already, since they weren't able to get these true spleen responses or full spleen responses at the outset. And you can see the waterfall plots. On the right is spleen volumes. The spleen's getting better there. On the left is actually changing symptoms. So this is helping with both symptoms and spleen in the second line setting. So we will see how this develops, but hopefully this is something that can contribute further improvements to some of our patients. Pelabresib is a BET inhibitor, and something that's also being studied. Really, the phase 3 study is predominantly in the frontline setting, but in the phase 2 study that they did, they looked at this in the add-on setting as well. And again, what we see is the ability to get further spleen and symptom improvements. And so the concept here is that maybe just a JAK inhibitor, ruxolitinib, maybe pacritinib, momelotinib, fedratinib, maybe just a JAK inhibitor is not the best we can do. Maybe we can do better and impact other parts of this disease by using some sort of combination approach. Maybe I use the kind of the metaphor of the JAK-STAT pathway in myelofibrosis is the critical pathway, and that's the interstate, right? But if you block the interstate, that may work to stop cars getting where they're going for a period of time, but over time they're going to take state roads, they're going to make roads, they're going to get around that. And that's kind of how the disease is. Yeah, we can block the interstate and we can help with a lot of that, but ultimately there's other inflammatory pathways that are activated that the disease will figure a way to get around. So maybe using a combination approach up front may have some value. Maybe adding on another agent in patients that are showing some signs of progression may be able to allow us to get further benefit. Luspatercept is an approved agent for MDS, low-risk MDS requiring transfusions, and is shown the ability. The way it acts is it actually allows red blood cells to grow up, and so we call it a terminal differentiation agent. It's something that's approved for MDS, but also is being looked at in myelofibrosis. The idea of this is to add it on to a JAK inhibitor in patients that are anemic. To see if this helps. The phase 2 study showed that in patients that were on Jakafi, that were requiring a lot of blood transfusions, where this was added on, was able to make around 30% of patients go from needing at least two units of blood every month for the last 3 months to need no units of blood. All right, so overall, that's a high bar to meet, and it was able to do that in 30% of folks. It was able to improve anemia and more. So if you look at this cohort 3A on the right, you can see that a mean hemoglobin increase of at least 1.5 grams was seen in 64% of patients, albeit small numbers. But this could be a very relevant agent for patients that are requiring transfusions, but otherwise are tolerating their current JAK inhibitor quite well and don't really like the idea of switching to a different one. You could potentially add this on as an infusion once every 3 weeks to get some anemia benefits. Parsaclisib is an agent that's emerging. We don't have as much data from this as we'd like at this point, but we will get more at ASH this year where it's going to be presented. And so parsaclisib, again, being looked at in the add-on and in the upfront setting. So we'll get a little more information about the responses that we see there. The limited data that we have seen show that we can get some degree of further spleen volume reduction when using it as an add-on agent, but we'll be excited to hear more about that going forward. Imetelstat, this is another drug that is being looked at in both myelodysplastic syndrome and in myelofibrosis. Imetelstat's a little bit different than all these other things we've talked about. So imetelstat's actually a telomerase inhibitor that we think is acting at the underlying stem cell level. And so it's been a little bit confusing to us to understand how we're supposed to look at this. Because it doesn't necessarily lead to these drastic spleen responses or symptom responses. But there's evidence that maybe it's doing something even further under the surface. And so in the phase 2 study they did, they looked at a couple different dose levels of imetelstat. And what was seen is in this kind of really refractory group of patients that we already said don't do that well long term, they lived a lot longer than we thought they would live. They didn't show a ton of spleen and symptom responses, but it's not how the agent necessarily works. And so with that, they've developed a phase 3 study that is randomizing patients to be on imetelstat versus best available therapy with the endpoint of being overall survival, which I think is super relevant. And it's the first time that's really been done in a myelofibrosis trial, which is we're not trying to see how many people got their spleens to go down 35% or how many people had a 50% reduction in their symptom score. We want to see if this helps you live longer. Is this acting at the core of the disease? And I think that's admirable and rational. This is how the drug we think it works. We think it might make sense if it helps people live longer, and that's what we're going to test. So I showed that kind of first breakdown of second-line options, but this is how I view the potential future of second-line options, where we have patients that are JAK inhibitor experienced. I'll say that. It used to be that we would say, JAK resistant or JAK intolerant, but I think JAK inhibitor experience makes more sense because we talked about that very few people come off of this for true progression of the disease. A lot of times it's going to be because they have a side effect that may be unique to that JAK inhibitor they're on, and so we may consider other options even though if they're not truly resistant. And I think we should do a better job of switching people to the optimal agent earlier on. We should be able to identify patients early where this isn't the best option for them. When we have other options, we can be more thoughtful. Before, we only had one option, so we just kept people on for as long as possible, which is probably why the survival after coming off it wasn't that great, because we didn't have other things to do. But now we can consider the specific patient in front of us and individualize therapy for those patients. So here, in patients that may have persistently large spleen or symptoms that aren't controlled with their current JAK inhibitor, you can consider switching the JAK inhibitor to another one or adding on some other agent that makes sense for that patient, parsaclisib, pelabresib, and navitoclax. For progressive splenomegaly, where spleens are actually getting bigger on the JAK inhibitor you're currently on, then I would argue that you should probably switch to a different one, right? That one's not working anymore, and we have other ones to do. So then you can add fedratinib, you can think about imetelstat, this navtemadlin, which I didn't go into too much, but that's an MDM2 inhibitor, which is quite interesting from a disease standpoint. We have parsaclisib, pelabresib, navitoclax. All of these things are in phase 3 clinical trials with the potential to get approved over the course of the next few years. So the landscape really is changing. For transfusion-dependent anemia, I mentioned maybe that's not the most ideal thing to have and just deal with like we have in the past. Maybe we should try to improve that too. So you could add on luspatercept, you could change to momelotinib. Pacritinib has emerging data that suggests it may be able to help with anemia. Pelabresib actually shows the ability to maybe improve anemia in some of the phase 2 data. And then we have navitoclax, which shows something similar in a small number of patients as well. Really low platelets, options may be pacritinib. Momelotinib also was studied down to 25,000 platelets, so this could be an option as well. And then we have, again, the area where I would say we've made the least progress, which is this accelerated phase and blast phase disease. And this is really where we need to be focusing on and bringing better options to patients. There's a bunch of reasons why we haven't done better in this group, mainly because when we look at AML trials, a lot of patients with prior myeloproliferative neoplasms are excluded from those trials, and so we haven't really been able to see how some of these new agents work in that group of patients. And overall, it's just a challenging group of patients. The patients aren't challenging. The disease is really challenging. It's a challenging group of challenging disease, and so everyone's different who has this. When you truly have blast phase disease, it happens in different ways. There's different molecular drivers. There's different bone marrow. The fibrosis levels are different, and so we can't necessarily test these broadly. We have to look at each individual patient. So that's kind of the next step of where we're going to go with this. All right, that's it. Number one talk down. So we're going to talk about symptom assessment and treatment, and there will be slight overlap, I think, probably between these slides, but I don't think there's a ton. Because now I'm going to get down to like the specific symptoms and what we can expect from our current therapies and how we look at this. And I'm going to kind of bring in some Seinfeld. I think this is, Jerry's not a very caring person, but this is something that we have to think about. And when we're seeing patients in the clinic, I think we need to think about what are the symptoms that matter the most to them, and what are we trying to accomplish from these with the treatments that we currently have. In general, I think that there is a tendency for patients that I've seen that have come in that symptoms are somewhat underestimated, or they've been told that perhaps these symptoms are not related to their disease, that it's related to something else. And I think that is a common misconception. And I'm not sure if it's a lack of understanding that leads to that, or if it's a bit of frustration in the community to suggest that, if you can't change something or meaningfully help with something, you kind of want to ignore it or not attribute it to the disease. But truly, symptoms are one of the most problematic things with myeloproliferative neoplasms in all of them across the board, and they are disease-related for the most part, right? And so we need to kind of accept that and also accept our limitations in being able to help some of them with the current treatments that we have. So in this, I'll kind of talk about the incidence, the spectrum, the impact of these MPN symptoms. We'll go over kind of what we know about JAK inhibition on the symptoms, and also the impact of treatment on symptoms in PV and ET, and then some emerging agents that are coming down the pipeline. And so here, if you think about kind of the percentage of patients who have MPN-associated symptoms by diagnosis, these are kind of the classic 7 symptoms or so of myeloproliferative neoplasm patients: fatigue, itching, night sweats, bone pain, fevers, weight loss, and spleen pain. And certainly those are down in, what you can see is fatigue is reported by nearly everyone with a myeloproliferative neoplasm, and it doesn't matter if you have ET, PV, or MF, this is something that patients experience. After that, you see itching, which is somewhat more common in patients that have polycythemia vera, but still seen in a lot of ET and myelofibrosis patients. Night sweats, bone pain, more common in myelofibrosis than PV and ET, but still there. Fevers, weight loss, spleen pain, somewhat more rare, but certainly causing some significant issues. This is looking at this in a slightly different way, talking about the symptom incidence and severity by disease type. So you see ET, PV, myelofibrosis, and overall. But again, you're seeing the same types of symptoms here with the kind of addition of things like inactivity, concentration problems, early satiety as well. So these are what we call the common MPN type symptoms. And if you look at it by disease type, you can see there's this kind of continuum that it seems like myelofibrosis patients tend to have more skewing to the right here, so maybe more severe symptoms to some degree, but they're largely similar between ET, PV, and myelofibrosis patients. where very few patients are truly asymptomatic. So on the left here would be a symptom score of 0. This is someone who feels relatively normal. You're seeing that's 15% of patients with ET, so that means 85% of patients have some degree of symptoms associated with the disease. With myelofibrosis, we see a little bit more severe symptoms, but again, most patients have some degree of symptoms. You're not supposed to be able to read this. That's the idea. But these are cytokines, right? So this is more for Dr. Risar and Rajit, to understand. These are these kind of inflammatory things that cause inflammation, or the byproducts of inflammation that have been associated with different disease and lead to certain symptoms. But it shows how many of these things get created in this deranged inflammatory process we call a myeloproliferative neoplasm. And it'd be great if it was just one and we could target it and get it to go away, and then people would feel better. But it's not. It's like it's 25 of these have been somehow implicated in a myeloproliferative disease to cause some sort of symptom or be associated with some aspect of the disease. And targeting each one individually is probably not that rational, but trying to figure out some way that we can shut down or regulate these cytokines to decrease this level of inflammation may be helpful. I find this is an interesting graph because this correlates kind of the incidence of symptoms, but also the impact or the correlation between that symptom and patients' perceived quality of life. And what tends to be the symptoms that associate most with decreased quality of life is fatigue, concentration problems, and depression. So those are probably the 3 symptoms that most correlate with patients' worsening quality of life. And so we need to be aware of these, I think, when talking to patients, and know that these are the things we need to be most focused on. This is, we can improve their abdominal pain or their symptoms, but if we don't think about or consider their depression, their inability to concentrate, their inability to focus, or their fatigue, and we don't kind of talk about those or mention or ask about those, then we're probably not going to improve their quality of life. We're going to improve one minor aspect of it, and then they're still not going to be feeling well for various other reasons. So this is something that we do need to kind of ask specific questions, because some of these things are not things that patients want to necessarily talk about or bring up in the context of a visit. So what do we know about our current JAK inhibitors and what they do for these specific symptoms? So I mentioned in the previous talk that JAK inhibitors tend to improve symptoms, but what about specific symptoms? So this is kind of looking again globally at symptoms. So this is on the top right what ruxolitinib did to improve symptom scores. So improves, like the higher that goes, that means the higher percentage of improvement in symptom scores over time. So you see a rapid improvement in symptom scores, and that seems to be sustained. So a lot of people were getting around a 50% improvement of their symptoms compared to placebo, where the symptoms weren't changing that much. On the right, or on the bottom right, you can see this waterfall plot of improvement in symptoms going down. We tend to see much more improvement in symptoms with ruxolitinib compared to placebo. Again, you're not getting anything, so this is the Comfort 1 study. But we know broadly Rux helps with symptoms. So here's to feeling good all the time. I don't know if you know that episode. That's a good one. So what about specific symptoms? So this is kind of broken down into abdominal discomfort, pain under the left ribs, early satiety, night sweats, itching, bone or muscle pain, or inactivity. And we see obviously placebo doesn't do much for that. If we don't treat these diseases, those symptoms tend to get worse over time. But if you do, Rux has the ability to improve all of these to some degree. I will say bone or muscle pain is probably the least affected in this study compared to things that have to do with the spleen, abdominal discomfort, pain under the left ribs, early satiety, night sweats. These are predominantly improved across the board. And so it can be quite helpful for a lot of different symptoms. The Comfort 2 study, which was largely done in Europe, looked at this a little bit different and looked at this global health status and quality of life and role functioning, so some more functional aspects of symptom improvement. And you can see with ruxolitinib there was a change and a general improvement in the ability to role or function in their role and have a better quality of life from that aspect. And then when you look at aspects of the disease on the bottom, there are slightly different symptoms there: fatigue, pain, dyspnea, insomnia, and appetite loss. Again, Rux helps some with fatigue, some with shortness of breath, some with insomnia, some with appetite loss. But I don't think this does a good job of demonstrating the percent change, right? Because if you have a 20% improvement in your fatigue, how meaningful is that? Versus if you have a 5% or 100%, right? I think that there's mild improvement in some patients, but I still get the sense that there's some symptoms that are not fully improved with JAK inhibitors. So yada, yada, yada. Anyway, I'm really tired today. All right, so what about fatigue? So I think that this is inherently, we said it's the most common symptom, but I think inherently this is the symptom we've done the least to help with. And we see patients with PV and ET where ruxolitinib is something that we have an option to use in those patients who are very symptomatic. But when that symptom is fatigue and profound fatigue, and that's the main symptom, I've had very limited improvement in that one symptom when it's the driving symptom. And the studies seem to show that Rux does help some with fatigue, but the percentage change is around 15%. And so maybe it is that it helps slightly, but maybe 15% doesn't matter a ton for a lot of patients. And so, I think that this is something where we heighten JAK inhibitors up as very good at controlling symptoms, but I think it's symptoms not necessarily. I think the fatigue continues to be the main symptom that is not as impacted by this. So what about other symptoms? Maybe something a little bit more rosy. So spleen response does tend to correlate with the degree of symptom response, as you might understand. So a lot of symptoms we talked about is pain on their left ribs and things like that. So this correlated patients that had either less than 10% improvement in their spleen volume, 10 to 35% improvement versus 35%, and it tends to be the better your spleen response was, the better your overall symptom improvement was. And so that's one reason why we continue to use this is somewhat of a correlate. What about specific symptoms of polycythemia vera, as far as pruritus, night sweats, and bone pain? So this is patients that were able to achieve at least a 50% or 100% reduction. So what you can see here is that the improvement in symptoms, some of them happen right away, and that's what you're going to get. So if you look at itching, that's something that you typically get a benefit of really quickly, and then those people are going to get that benefit. Bone pain and night sweats tend to be something that the degree of assistance or improvement of the symptoms tends to improve over time, and so there may be some benefit in staying on these longer term, because you can see these patients are going out to 144 weeks here. So we're on couple years here, or I guess 3 years here, and you're starting to see improvement in the full ability to control those symptoms. What about symptom change with other JAK inhibitors? So momelotinib and ruxolitinib. This is in the Simplify-1 study. So this is the one study where we compared two JAK inhibitors head-to-head in treatment-naive patients. So momelotinib was compared to ruxolitinib head-to-head, and we can see across the board similar ability of these to just improve symptoms altogether. But when you look at individual symptoms and say, hey, is there a difference? So this is comparing the two in terms of abdominal discomfort, pain, early satiety, feeling full early, night sweats, itching, bone or muscle pain. Pretty similar on a symptom-by-symptom basis. So if we're thinking about having these newer options available to us, we might have to start looking at this and say, hey, what's the symptom that my patient has? Okay, how is this shown to improve that symptom? Should I really switch from one JAK inhibitor to another? Are they going to lose something there? Overall, what we're seeing here is they're quite similar, even on an individual symptom level. Symptom improvement with pacritinib versus best available therapy. Again, we showed that pacritinib has the ability to improve symptoms globally, but when you look at the different doses, you can see these green bars tend to be the ones that go down the furthest. That means you're getting the best symptom improvement. That's the recommended pacritinib daily dose, and you can see across the board, quite good at helping with spleen pain, even some degree of bone pain. Inactivity, it probably does the least for, but has some help there as well. I referenced this earlier, but this is the patient global impression of change with pacritinib. So patients on pacritinib generally feeling to be, feeling better or improved compared to not as much on best available therapy. What about fedratinib on total symptom score? It also has the ability to help symptoms more globally, and that tends to be an improvement you see within the first 12 weeks and can be sustained out longer. Again, this shows two different doses of fedratinib, but we use the fedratinib 400 milligrams daily dose. And then ruxolitinib on symptoms of polycythemia vera here. So now specifically looking at PV patients and looking at its ability to improve those types of symptoms. Here there's a lot of different symptoms that have been thrown out, and across the board has the ability to do so. I will say, more moderate improvement in tiredness, as we kind of referenced earlier, a little bit more moderate improvement in concentration problems. And again, these are the types of symptoms that seem to correlate most with quality of life. So I do think that we have the ability to do better than we're currently doing. Why isn't ruxolitinib approved for ET? Good question. It was looked at in the MAGIC ET trial. Unfortunately, didn't meet the endpoint. I have my thoughts on whether maybe that is the case or not. I think ET, as again we showed, it has a tendency to have less predominant symptoms maybe than PV and myelofibrosis. So maybe in the context of a clinical trial, it's harder to show that clear change. Also, I think some of the symptoms with ET are a bit different, not as many cytokine-driven symptoms, more platelet, blood vessel wall, neurovascular kinds of symptoms that may be going on there, where it's not as clear that Rux is better than hydroxyurea or current therapies. And so what we did see is that itching is drastically improved with ruxolitinib in patients with ET. So that's the one area where we still consider this to be the standard of care, and patients that have really refractory or profound itching tends to get better with ruxolitinib. Which made me think of that episode. She has the really long fingernails. So, but what do we know about, I think one of the things we don't talk about, we talk about symptoms with Rux a lot, but in PV and ET, we don't use Rux except for maybe in the second line setting usually. And so what about the impact of interferon and hydroxyurea on symptoms? We certainly know these can help to control blood counts. We presumably think they can help to reduce the risk of thrombotic events. We hope that interferon might have the ability to maybe decrease the JAK2 allele burden and maybe decrease the risk of disease progression over time. Hard to show that, but we hope that that's the case. But what about symptoms? And I think this is where the information is a little bit less rosy. So in this study, when you looked at the comparison of hydroxyurea versus interferon and symptoms over time, you can see that in those patients that have high symptom scores, these red bars, symptoms seem to improve mildly to moderately in patients with interferon and hydroxyurea. In patients that have lower symptom scores at baseline, the symptoms don't seem to get better. They seem to actually maybe stay the same or get a little bit worse over time. So it doesn't seem that these are the agents that help a ton with symptoms. Again, looking at these symptoms over time, you could see that if the bar goes up, that means the symptoms are getting worse. If the bar goes down, that means the symptoms are getting better. So in patients that have a high baseline symptom burden, there may be some benefit to interferon hydroxyurea in improving those to some degree. But in patients that have baseline low symptom burden, it tends to be that the symptoms kind of get worse in the face of hydroxyurea or interferon, at least in these studies. Again, this is not looking at ROPEG interferon. This is looking at pegylated interferon in these MPN-RC trials. What about this Dahlia trial? So this was a European study that's going to be presented at ASH this year in terms of symptoms. We're putting a plug in for you. This is going to be hot off the presses, right? ASH abstracts are just released, and so they haven't even been presented yet. So just going on based on what they put on the website. So the Dahlia trial was an interestingly designed trial where patients with myeloproliferative neoplasms were randomized. If they were older than 60, they were randomized to either be on hydroxyurea or 2 different forms of interferon. If they were under 60, they were just randomized to be on the 2 different forms of interferon. But over time, this is the assessment and how symptoms changed while on these treatments. And what we see is the change from baseline with hydroxyurea or interferon is not what you'd be hoping for necessarily. This is actually a slight worsening of symptoms over time on both hydrea and interferon. And the absolute change over 36 months, well, if you were able to be on it for 36 months, maybe it was a mild change, but overall there's a trend towards worsening of these symptoms over time. And so really I think hydroxyurea and interferon should not necessarily be viewed as symptom improving medications. Their goal is going to be to reduce the risk for thrombosis, to control blood counts, but if you're looking for something to help with symptoms, it may be something we need to look at a different agent. I'll mention rusfertide here. This is PTG-300. It's a hepcidin mimetic that is looking at symptoms to some degree in polycythemia vera through a different mechanism. And so we know patients with polycythemia vera, one of the mainstays of managing the disease is to provide phlebotomies, right, which is somewhat archaic. We don't do leeches, but certainly this is somewhat archaic, to just drain blood from them every so often to keep their blood at a safer level. And this leads to a host of problems. One, a lot of these patients are older, and you're sticking a needle in their vein over and over and over. You're crushing their veins. They're not able to get repeated phlebotomies. Patients are then asking for a port. That's the last thing I want to give to a PV patient at risk for thrombosis is an indwelling catheter that's just going to create another nidus for some sort of clot. They're also not tolerating fluid shifts that well, so you take 500 cc's of blood off them, and they pass out in the clinic, and you say, no, it's fine. You're safe now, right? You're not going to get a clot as they're passed out. That's not ideal. Also, we kind of induce this cycle of iron deficiency, which is something that causes its own host of weird symptoms, right? So you have patients that are iron deficient when they show up because they have a JAK2 mutation, which uses up all their iron. And then you go, no, the way we're going to protect you is we're going to take blood from you and make you more iron deficient. So then their body's like, well, I'm more iron deficient now, so now I got to use up the iron that I have to make more red blood cells. And we're like, oh, but you made too many, so we're going to take some more blood from you, and this cycle isn't great. And so rusfertide is this hepcidin mimetic that tricks the body into thinking that it has enough iron, but it withholds it from the bone marrow, so it can't use it to make blood cells. And so what we've seen is that it really gets rid of the need for phlebotomies quite quickly and quite effectively. And what we need to know, or what we need to find out, is whether or not this is going to translate to improvement in how patients feel. And we haven't really been able to assess that too much. I think the one kind of slide we've seen is this improvement in concentration, which seems to get better, from baseline to week 28 in patients that are on rusfertide. But overall, I think that's where we have to see if this drug is going to be critically effective. Is okay, great, it reduces the need for phlebotomies, but does that translate to meaningful outcomes as far as, do people feel better? Do they have less clots? Are they more protected? Because I don't think this agent is going to have too much impact on other blood counts, right? We've shown that white blood cells stay about the same, platelets stay about the same. It's not acting at the core of the disease. The real goal of this is to reduce the need for phlebotomies and make people feel better from that standpoint. So we'll have to see where that goes. There's an abstract that's also going to be presented on ROPEG interferon alpha 2b, which is Besremi, which hopefully we get a little bit more details, because I think my one issue in the ROPEG trials is it's very effective at controlling blood counts. The molecular responses there are very encouraging, especially on long-term treatment. Certainly has transformed what we can do for patients. Seems better tolerated than prior formulations of interferon. But we haven't seen too much as far as how patients feel in the symptom responses. And if we have, it's been just slight mentions that, patients generally felt better. But I think we'll hopefully get some more details going forward on what exactly that means and how patients. So we know that in most patients, they kind of made this reference during the last presentation at EHA that generally patients had low symptom burdens when they went on the trial, and they stayed with relatively low symptom burdens throughout. What about non-drug things, right? I just get up here and talk about drugs the whole time. But I think what we've realized, especially for fatigue, is non-pharmacologic interventions are probably more successful in improving symptoms as far as fatigue goes than some of what we have from that standpoint. And certainly, it's not necessarily like the sexiest thing to talk about is like, hey, maybe you should sleep better and eat a healthier diet and exercise a little bit and take care of yourself. But honestly, these have more meaningful outcomes for my patients than I think that adding on another medication that comes with its own host of side effects and interactions and financial toxicity and concerns there. Because it's great to give them a drug that improves your fatigue by 15%, but if it makes you pay $900 out of pocket, and then you're just you have an ulcer from all the stress of that's not going to really overall help your overall quality of life. So there's ongoing studies. Ruben Mesa has really been kind of the pioneer from looking at different ways to address these symptoms. So people have looked at the impact of yoga and meditation and mindfulness, and it turns out that, weirdly enough, these things that have been done for millennia tend to help in your overall quality of life and health. And so it's just actually making the time to get down there and do that. So certainly do encourage these strategies as well. So what are we going to hear at ASH this year? So ASH is in 3 weeks, something like that. So this is kind of a breakdown of novel agents that will be discussed at ASH this year. So we're going to hear about ruxopeg. I know this is something of great interest to many of my patients. What do we do when we combine ruxolitinib with pegylated interferon? Can we do that? Who should we do that in? Why should we do that? What are we going to get out of that? I think it makes sense rationally. You're thinking about Rux helps with symptoms. Pegylated interferon may help with disease changing and stuff, but is there a patient population where putting them together makes sense? Talked about the addition of parsaclisib to ruxolitinib, upfront combinations of navitoclax and pelabresib with Rux, the addition of this HDM2 inhibitor, siramadlin, to ruxolitinib. We'll hear about a PEM inhibitor Dr. Rampal's involved with that we'll use for patients that are kind of ineligible for ruxolitinib. Updated long-term data from the Momelotinib Momentum study. We'll look at the pacritinib impact on anemia. As I mentioned, that is emerging as a possible option. We'll see ROPEG interferon, some data in now myelofibrosis, so pre-fibrotic or early phase disease, where interferons may make a little bit more sense. In PV, we're going to see ruxolitinib versus best available therapy in patients resistant to hydrea, but we're also going to see the impact of ROPEG interferon versus standard therapy in the low PV study. So a group of patients, traditionally we just did phlebotomies and aspirin. Now we're thinking about maybe bringing interferon to the forefront there to see if that does better. With ET, truly there are trials going on in ET. I know it's almost forgotten to be like the lost cousin in these clinical trials, but we're starting to look at ways we can impact the underlying disease there with bomedemstat, the LSD1 inhibitor, which is very effective in reducing platelet counts and may have some ability to impact the underlying stem cell. Then ruxolitinib versus best available therapy in this RUXO-BEAT study. So this is kind of an upfront trial of ruxolitinib versus best available therapy that includes patients with ET. So to be determined on where this, where the field's going, but we're looking at a lot of these things. And I will mention in all of these trials, symptom assessments are being done, right? That's one thing where I think we have a lot of other diseases beat is we're constantly focused on how patients feel on these medications. So what are the conclusions from this? So I'd say aside from transplant, main focus of treatment is still on improving disease-related symptoms. That's where our focus is. Fatigue, inactivity, depression are the symptoms that most closely correlate with decreased quality of life. JAK inhibitors have the most substantial impact on symptoms, but the degree of impact really depends on that specific symptom. Cytoreductive therapies like interferon and hydrea have a more marginal impact on symptoms. Non-pharmacologic and pharmacologic mechanisms should be considered to reduce symptoms, improve quality of life. And we have these emerging therapies that I'll echo my colleagues that we're very optimistic, right, about the future and how we can change things. So emerging therapies continue to incorporate symptom responses as key endpoints in these registrational clinical trials.